Good afternoon, and welcome to When to Pull the Plug, Strategies for Building an Application Decommissioning Discipline. This is a health system CIO production. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You could send in your questions or comments at any time in the Q&A box, and we'll address those later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35 to 40 minutes with our main panel discussion featuring Dr. Zafar Chaudry, former Chief Digital AI and Information Officer with Seattle Children's, and Adar Palis, SVP of Clinical and Revenue Cycle Applications with Providence. And then we will have our Q&A. So let's jump right in. Dr. Chaudry, you want to start off by telling us a little bit about your former organization and what your role was there.
Yeah, so hello everyone. Thanks for joining. Pleasure to be here. Yes, I was the former person leading the technology team at Seattle Children's, most recently left their pediatric health system, about $4+ billion, 46 sites across Washington, Alaska, Montana, Idaho, really focusing on that pediatric space. And I left there about 90 days ago, so currently in between roles, but pleasure to be here.
All right, thanks for joining. Adar?
Hi there. Thanks for joining. And I'm Adar Palis. I'm the SVP over the technology platforms here at Providence. Providence is about 52 hospitals. We have over 1,000 clinics from Alaska down to Texas. So very West Coast based organization. So my team manages all applications that are either patient or clinician facing.
Excellent. All right, let's jump right in. Dr. Chaudry, we're going to start with you. I think it's useful to just analyze the state of things in healthcare, and we have to generalize in order to do that. But we're going to say, what do we think is a general state of things out there as pertains to application sprawl, excessive applications? The theory is that this is an issue at probably all health systems. We have probably more than we need, more than we're using. Consolidation is good. But your thoughts on the current state are sort of describing the problem issue.
I think over the years we went through the cycle of more is better. And as people saw new applications, they wanted them, and then they were implemented. But now I think with the cost of running support services and the cost of supporting clinical care, which continues to rise year on year, there's more of a life cycle type approach to the application sprawl that you mentioned. But it's always easier to turn something on than to turn it off, right? Because it's multiple stakeholders involved, usually not that many involved in turning it on, but once you turn it off, everybody has this theory of, I need it. And then it works through, you have to work through a structure to try and figure out how you can actually remove or reduce those applications. But I think every organization has the ability to right size if they have the appetite to put the work in to actually make that happen. And I think that's still, for me, questionable as to everybody says they want to rationalize things, but actually getting it done, building a governance around it, getting the approvals, and most importantly, following your state regulations around data security and data retention are things that people don't really look at. If there's a cost to run a legacy system, but there's also a cost to archive data. And most people haven't thought those steps through, but are very good at saying, well, this could save us money. But it also would probably cost money before you can save money. Maybe more invest to save scheme with a longer term projection.
All right, very good. Adar, your thoughts on the current state. What do you think most health systems are dealing with right now in terms of application sprawl?
Yeah, I mean, I think it's a cyclical effect. So it was standardization, then it was best of breed, and now we're looking back towards standardization again. And for many of the reasons that Dr. Chaudry already had mentioned, is it is really easy to find a niche product, have it turned on, turning an application usually as a sponsor has funding, enthusiasm, a business case. However, turning it off, you have to unwind workflows. You have to look at the contracts, the integrations, the training, the archive data, everything that was already mentioned. And I think um, one really big thing is that cybersecurity risk of some of these legacy applications. It is becoming much more of a threat than it ever has been, and they need to be patched. They need to be managed. We've seen in the news across the country where there's been cybersecurity attacks, ransomware attacks, where these folks have got in through a little known application that folks didn't even know existed in many cases. It wasn't being kept up, wasn't being patched, etc. And so I think now it's not just a matter of, is the application usable? Is there a cost savings? But now, does it present a serious cybersecurity risk?
Yeah, we call it, that's the attack surface, right? The more applications, the larger the attack surface. Adar, when we talk about application sprawl or applications in general, and we talk about trying to clean this up and rationalize them, is it important to distinguish between in suite and out of suite or niche? Are we much more concerned about the niche products, or are we equally concerned about sprawl within the platform? Do you know what I mean? Does that make sense?
Yeah, I mean,
Yeah.
absolutely, because I think both, and the reason why is the challenge isn't necessarily finding applications to retire. It's really the challenge is about creating the discipline to retire them, to find the evidence that says the organizations move beyond them, and whether that's something that is inside an application suite, or it's a niche product. Now, one could argue that maybe one that's within a suite is being kept up more, is being updated, because usually some of these larger vendors have the resources to do that R&D where niche products may not. But a lot of times it really is just trying to find the discipline to be able to understand and rationalize out. This isn't being utilized anymore. It's not benefiting the organization like we thought it would. And again, that's regardless of whether or not that's part of a suite or it's a niche product.
Dr. Chaudry, thoughts on that?
Yeah, I think turning tools off, it's infinitely harder than turning them on, because buying software is a singular event, and when you're retiring something, it's more of a complex project. And a lot of times you keep this legacy niche software on life support because of clinical anxiety over losing historical patient records. And some products that people buy, which are SaaS-based solutions, they sort of silently auto-renew themselves because people don't track when is the right time to exit. But I think leadership turnover often leaves niche applications orphaned without a clear owner assigned for that particular off switch. And that sort of then leaves IT teams hesitant to decommission these applications because they fear that if they do, they might break unseen critical clinical workflows. I mean, one thing we're not very good at in health IT is actually writing anything down.
Mhm.
So as you go through cycles of people coming in and leaving and coming in, you lose that institutional knowledge, right? And so if it's not written down and I go to a team and say, here's 5 applications I think we should turn off, the question always arises, well, who owns it? Who makes that decision? And if we just turn it off, what would that mean to the organization? And of course, even if you have one person logging into that application and hasn't logged in for a really long time, they will notice when you turn it off.
Mhm.
And then there will be escalations and all the things that come with, well, why was that done?
Yeah, so you want to get ahead of that, right? You would want that individual or individuals to be notified. You would want a smooth process. Let me lay out some things I was writing down, and I'd like you to address them. Dr. Chaudhry, you can go first. Um, it seems to me when we're looking at applications we may want to retire, you could have a couple scenarios. Use in one bucket, meaning people are using them, and essentially no use. I don't know, and we can get into this, how you determine use. Can we determine how much and who is using this application? And if something's dead, then we take very little risk. No one's logged into this in 3 months, so we're not that worried about it. And then, but it's even more complex than that because use can be divided between a lot of use or an extremely small amount of use, and even a very small amount of use from a very high level clinician is not something to mess with, right? It could be three surgeons use this thing, and as a pure number, it looks ridiculous, but you shut it off and you will get phone calls within 30 seconds. There's lots of nuance here. How much can we find out so we can create a path forward? And how much is sort of, well, we've just got to shut some stuff off and see if anyone calls?
Yeah, so I think the authority to decommission any type of tool that you find, legacy or not, doesn't rest on a single individual's shoulders. But actually, what you have to do is you have to back it by a unified governance structure or committee or board. And within that, you have to include key leaders who can evaluate that usage, that system from every angle. So, for example, if you're a CIO, you would look at that technical feasibility, the infrastructure overhead, the security risks. If you're a chief medical or nursing officer, you're going to evaluate that clinical impact to ensure the workflows are safely rerouted into another application or maybe a core application. And at the same time, somebody like a CFO would quantify the total cost of ownership of that against the expense of archiving it, or whether or not the clinical business owner represents day-to-day users who advocate for its operational needs. But to prevent all of this, which is going to turn into some sort of political turf war, you've got to build a standardized governance structure. And within that is where you're going to establish clear thresholds for usage, clinical efficacy, security compliance. The decision to decommission then becomes part of a group a group decision-making process. So yes, absolutely, you're correct. There are some applications where you might have two users, but if those two users happen to be neurosurgeons, and it's a very specific application for neurosurgery, turning that off could potentially put the patient at risk. But if you build a standardized governance structure around that, you would look for those subject matter experts to have an input into that, and then collectively you could make a decision as long as the rules were followed around archiving and retention of data. Then you potentially could get rid of that application and archive that data. But it's a long-winded process, requires a lot of input in a climate where when you ask people, can you join another committee? They're already overwhelmed with committee work, right? So when people start these bold programs of, I'm going to cut 20% of our applications and save all this money, and that usually comes from an IT initiative when they're planning for a new fiscal year, as that fiscal year actually starts and operationalizes, and you get to the end of the fiscal year, you realize you never realized that 20% cut. It may have been more like 5% or 6% just because of all the things you need to do to get those approvals.
Otter?
I actually, taking a step back, I think it's less about usage, because I mean, even folks could be using an application, but have they quietly found a way to work around it? Do they have strong indicators they've routed around that for a different solution? Instead, look at the value of the application. So is it actually improving clinical or operational or financial outcomes? And so using the neurologist example, I mean, if the tool is providing value to those neurologists, then that to me tells a bigger story than is it 2, 3, or 100 people using it. Because we've seen applications that are being used by a number of people, but they're not actually finding any value out of it. They are instead having workarounds, because people are, operational folks taking care of patients. They are amazing people, and they find ways around inefficient tools to be able to take care of the patient. And so how do we make it easier for them? I totally agree. There needs to be a governance structure. It shouldn't just be arbitrarily removed, but I think part of it is is really strongly looking at the value that these tools or these applications are providing, rather than just simply is it 5 people using it, 10 people using it, or 100 people using it.
Adar, who's going to be driving this, if anyone, in a health system? Is it the CIO? Is it more of a title like yours? Like, I think there's an issue here of, and you both alluded to it, is the juice worth the squeeze? I think
Yeah.
the expression is this could take a tremendous amount of capital, a tremendous amount of work, and a tremendous amount of time. And I wonder if it's the kind of thing where if you put 100 applications into the governance review pipeline, you might there might be turned back from shutting it off in
Right.
95 cases where there's some reason that someone held up a veto and you weren't, so you did all this work and you got a little bit of juice out of the squeeze, and maybe that's just the way it is. Maybe that's worth it. Maybe the CFO is saying, yeah, do this, like whatever it takes, this, even if you only reduce 5%, but someone's got to care enough about this and see enough benefit to drive it. What are your thoughts?
I mean, I think it needs to start with you got to have an inventory, right? You got to where are you starting with? So to your point is that if I have 100 applications, I'm not going to take all 100 through. Because to my colleague's point, I think you do need to have a number of different folks on this group to make that analysis, and 100 applications is going to be too much. So you've got to weigh, is there a financial outcome? Is there clinical value or revenue cycle value that's being produced or not, or lack thereof? Is there um, uh, overlap with other applications, et cetera? And so some type of a scoring mechanism to be able to say what of our highest priority, what will, to your point, have the biggest juice for the squeeze, to be able that can rise to the top to say this is what we want to focus on in this group. Having a group of CNOs, CMOs, CIO, et cetera, operational leaders, that's hard to come by.
Hmm.
As the good doctor mentioned, I mean, trying to get people to join another committee is difficult, and so you got to make it a valuable use of their time. So how do I get a small subset of that inventory to say, look, these are ones that can make the biggest impact. They have, a financial impact. They have, there's a ton of workaround that's happening with these current applications. These ones are being used by thousands of people but are offering no value whatsoever. We're double spending on a number of these things where we have a suite that's offering it, and then we have a niche application that's offering the same thing, and we're spending a lot of money and time maintaining it. It's a cybersecurity risk. I mean, you can see all these different levers that you can use to be able to identify which ones kind of float naturally to the top to have those discussions, to be able to utilize that governance group effectively and efficiently, to not sit down there and say, okay, we got a list of 100, we're going to go from 1 to 100, in alphabetical order. No, you need to have a number of the things I just mentioned to be able to rank them so that you can really utilize people's times effectively.
So it's like a multi-factor ranking. It's
Correct.
not like let's just start with usage because that's easy. Let's start looking at from lowest to highest. We assume possibly things that
Right.
are have very low usage at least should be looked at more than things with very high usage. And I understand what you're saying. There's a lot of nuance. High usage doesn't mean high value, but there could be some correlation, at least,
Correct.
you start at that point, then you put them through the pipeline, they get evaluated in a whole number of angles. To your point is, there could be, it could be used, but there's, maybe the niche product is being used, but oh, now our in-suite version is, can we look at that and see if the functionality is the same? Because we have some benefits of going in suite. So
Right.
there are a number of ways to look at it. So each one does need individual attention with that committee that's properly constructed. If you can get people to buy in, which you usually can do if you have the proper executive sponsorship. Does all that kind of
Yeah.
All that adds up. And don't forget, I mean, again, I wouldn't, the cybersecurity risk is a real important piece. Because again, we can't, something might be highly utilized today, but is the vendor's no longer patching it. They're not providing updates. It's running on old technology that we can't update. I mean, I think we've all seen those in our career, and But I don't want to be responsible for allowing an application to open up a hole that causes a 0-day event in our organization.
Dr.
Yeah,
Chaudry?
these programs, we talk about saving money, but this is really another change management program. And change is really difficult, and change has a cost because you can deprecate an application and then you can come up with, well, that functionality exists in our EMR for it, for example, but then you're going to have to train people to use that functionality in that EMR. And that's actually going to have a cost. And then that's going to take a whole set of other people. And that is going to take time and is going to cost money as well. So I think my colleague is correct in there's a lot more to this analysis than just it would be a good idea to turn this application off because it saves money. I think you have to work through, yes, the governance, but don't overly govern it. But at the same time, there has to be an analysis to say those three people potentially using that niche application will need to use something else. And what would it take to get them to use something else? How much time will it take? How much would that cost? And is that in already an existing piece of software? And most organizations will probably have anyway in their portfolio 1,000+ applications that they run on a daily basis. There's a lot of challenges around lack of utilization anyway. I mean, the average software product is used, what, 25% of its capability? And that includes products like your EMR or ERP. The number of clinicians you bump into who are like, I didn't know the product did that. Because how do you train thousands of people with at the elbow support all the time? You don't.
Mm.
So I think those are all the things you would factor into what people start off with as an application rationalization program of works that's going to be amazing and it's going to save us millions of dollars. And then as they work through it with their partners in the committee, they realize that, going back to your juice and squeezing analogy, not much came out. The lemon was slightly rotted in the first place. So when you squeezed it, not much came out, right? And then you realize, well, how much did it cost to get to that point? Because you might ask people to volunteer for a committee, but every person on that committee has an hourly labor cost that's never really factored into that model. So I'd love to see at some point an organization publish the actual true cost of retiring an application, including the labor costs to get it to an agreement and the archiving and all the other pieces. And then sometimes you look at an application that you bought from three people on a boat in the middle of nowhere and realize that what they're charging you per month is just cheaper to keep it on.
That's another good point.
Right.
That's another good point. So, to go with my analogy and to I'm making myself laugh here, the juice and the squeeze, right? When it's not worth it, you also could say my hand hurts, right? My hand hurts and I didn't get any juice out of it. That's doing a lot of work for nothing. So that's kind of funny. Um, what's interesting to me is we talk about the governance, we talk about committees and proper representation. I'm picturing people having a discussion. There's a leap between a discussion where everyone provides their input verbally and anecdotally and a decision when we have to take in many factors and many opinions and many angles. We mentioned cybersecurity. We mentioned the cost of switching, the cost of training, the value to the clinicians or the users. There are lots. I'm picturing one of those chalkboards where you have an astrophysicist working and you got a lot, like the chalkboard's filled, and you want to be able to take all this. If you had some beautiful, perfect formula, you could shove all this stuff in and it spits out exactly what to do, right? Archive it, do this, do that, or whatnot. So, short of that, when we have all these things, including the sort of the IT side factors like cybersecurity and whatnot, and the user side factors, how do we get any sort of rational output where everyone goes, yeah, I trust that decision because it went into our perfect black box formula and it always spits out the truth. Otter, what are your thoughts?
Not an astrophysicist, so gonna have to say that I don't have a nice formula for that. But it's also not blind trust. I mean, it is sitting down there and trying to. I mean, most people are rational people, and so you need to get. So from a CFO perspective, here's the numbers. Here's what it costs. Here's what it would cost to shut it off. Here's the savings, etc. Here's the for the cybersecurity, here are the risks, et cetera. For the operational folks or the clinical folks, here are the comparison to what the tool did and what the whether it's a EMR, legacy EMR, new EMR, et cetera, that has that tool in suite and kind of a like for like comparison. So I think it is sitting down there and appealing to everybody to say, okay, we checked everyone's box here. You're here to represent. You're in this committee to represent subset or a portion of the organization, your specialty, your area, et cetera. And so we've got to be able to ensure that we're giving you enough information in your area to say, is this really worth it? Maybe it's not. Maybe there's a low cost to keep it running. There's a low risk to keep it running. There's only a few people that are utilizing it. Then, should we even be spending our time on this? And so again, I wish that maybe I need to go back to school, be an astrophysicist, and I'll figure it all out. But in the meantime, I don't think that there's a perfect formula. I think it is looking at your committee and ensuring you have the information to be able to give to each one of those different members. You have a nice cross-platform of folks to be able to participate and be able to give them the information, help them make a decision, and then help them understand why you're there. What are you representing? What area? What's your specialty? Those types of things to be able to help make a decision. And I think you go from there because there's just never going to be a perfect formula that you can plug it into and make a decision.
Dr. Chaudry, when we get down to the nitty gritty of these governance committees, are we looking for unanimity in opinion, consensus, or do we go with the Supreme Court and we'll take a 5-4 vote? I mean, how do we move forward? And, one of my least favorite things when I was working for another company, and it's been a while, is, well, let's table that and discuss it next month. Like, it's like that's the easiest thing, right? We just it's complicated. We don't have consensus. We'll talk about it next time. I don't know how it works in these type of committees. What are you looking for in order to move forward in one way or the other? Either we decided to keep it, leave it alone, or we're going to shut it off and now we're going to take the steps to move in that direction.
So I think the fundamental principle in any health system is that people want to be heard, specifically clinicians, right? Because the biggest mistake we always make is we make a decision, didn't seek or solicit any input, and then you have the escalations afterwards. So I would say that the purpose of any committee is allowing people a sounding board to be heard, and you understand the rationale as to the argument that the individual is making. But of course, it's a committee, so it has to be democratically run. And I also don't believe in over-governance, although many health systems are pushing over-governance now. The challenge with over-governance is if you constantly say no to something, people will do it anyway. And they'll do it, and that's when you get the rise of the shadow IT function. I'll give you the best example. If you say no to a researcher, they'll just go to Costco, buy a server, and put it under their desk anyway. And then they'll do what they need to do because they have an NIH grant that has a timeline on it. So what I would suggest is your governance structure is there to allow people who represent their areas to be heard, but fundamentally there's a consensus, and yes, it's a vote, but you have now brought all the challenges to the table and they have been heard. And sometimes it's okay to agree to disagree. So I think you have to work through it with that premise. And if there is a overarching strategic plan for the organization, then this governance committee of how we lead with applications or decommission applications should filter into and link into that. So the example I can give you is many organizations have a strategy that says they are going to be EMR first in everything that they do. And that means that all those ancillary applications that were doing small things and then they bought a singular EMR product, they never did that consolidation. So part of that governance committee is to going back to the true north of the organization. And if it is EMR first, then that factors into that conversation, as well as finances being one, clinical safety, patient outcomes, security, all those things. So you can actually build a matrix. And what I would also say is in the world of technology, and funnily enough, in this conversation, we've not talked about the dreaded AI, but the reality is that when you solicit input from 100 people, even through a survey about a decision, that information can now be mined very quickly, and you can automate some of this governance. So the intake process can be more automated. The themes can be more automated. So now you're sitting on a multitude of knowledge that tells you what people are going to tell you anyway, right? You're going to know what the objection points are, because if you feed all of the objections you've had over the last year into an LLM, it's going to tell you that, Zafar, before you do this, these are the 5 things that are going to hurt you because people are already going to say that to you. And so you could even provide some automation layers to speed some of the governance. Because what's the point of a committee that lasts years and years? And as to your point, Anthony, people love doing that in healthcare committees. Well, let's table this and bring it up at the next meeting. And then at the next meeting, there's 79 agenda items, and yours was number 80. And then they table it and they table it. Well, what that then generates is frustration. So you never want to build a governance structure when you're rationalizing applications that builds frustration because decisions are never made. And you have to assume good intent, but you also have to assume the 80-20 rule, that 20% of people are never going to like the decision that you make, but you have cover. So if you're a CIO, you have the cover because you made sure that the representation was correct from all the areas in that committee. So you do have some cover, even though people may still want to poke you in the eye because of the decision.
Very good. Adar, your thoughts?
Very similar. I mean, I think that, I mean, cover is good. I think the 80-20 rule is a great analogy because you're never going to make everyone happy. And if you go in there thinking you're going to try and get everyone to agree on a decision, then you probably already failed. That's not saying you ignore everyone, but the idea is, again, if you can get that as close to consensus as possible with some naysayers. It's also important to understand, and again, going back to making sure that people's voices are heard. Why are they naysayer? Are they a naysayer just because they're connected to the application, or that there's something that is really important about the application and the value that it's driving that you really need to hear? And I think so. It's trying to discern that. I think one of the probably one of the bigger pieces is really about a lot of the naysayers can be folks that were champions. They sponsored this solution back in the day, and so I think it's important to sit down there and say, hey, retooling or removing a tool or an application, this shouldn't be framed as a failure of that solution, of that individual that championed it before. It's really that we're talking about, we benefited from this innovation, we benefited from this tool at one point, but now we have a better, more scalable, even more integrated or embedded application if it's within your EMR that can provide the same, if not a better outcome. So I feel like when people understand that the decision is grounded, in data, in governance, in an organizational benefit, not necessarily a personal preference, the conversation can become much easier.
Very good. Otter, what do you see as IT's role in this process? We talk about the creation of a committee. Is IT sponsoring the committee, creating the committee, chairing the meetings, moderating the discussion? We don't want to be making the decision per se. We want to be a contributor to the decision because there are certain important factors that only IT is bringing to the table that need to be taken into consideration. But what is the ideal role of the IT executive in making this happen? Can they even be the one to at least decide this should happen,
Yeah.
or does that have to come from somewhere higher?
I mean, I think this. I think everyone agrees that it needs to happen. So I don't even think I'll be shocked if there isn't an organization out there that it isn't either doing this or contemplating looking at their application portfolio. So I don't think I think it's in quite frankly, it's an easy decision to proceed with something like this. I think IS's role or IT's role in this is we bring the information, obviously the application portfolio. We have tools and whatnot that can be able to show that inventory, but I don't think they should be sponsors. This is not an IT decision, as you mentioned. That this really is an organizational decision, and so it should be sponsored by a COO in partnership, maybe with a CIO, et cetera, CNO. Especially if they're on the clinical side, a CFO should certainly be part of it. If there are stuff in the financial realm that might need to be rationalized out. And so I think that it's IS's role or IT's role to be able to come to the table with some of that information, help facilitate it, help understand, because we can do a pretty good job of comparing apples to apples from an embedded solution to, say, the niche product, as we talked about. We have connections to vendors to be able to get demos if necessary, all those kinds of things. We can help facilitate a lot of the conversation. But at the end of the day, I really believe this needs to be an operational decision. To again, back to the idea of making sure people's voices are being heard. It's the old out of that when an EMR was being implemented years and years ago, and I'm dating myself, going from paper to electronic. That is not an IS decision. That should not ever be an IS decision. That should be an organizational decision. And so I think it's really important here in the same vein that this needs to be an organizational decision, not an IS decision.
Dr. Chaudry, thoughts on IS's role in either starting this snowball moving down the hill, and then once it's moving, how they should be positioned within it?
So I do agree with that view. I mean, ITIS is a support function within a health service, and their job is to serve the customers, whether they're clinicians or whether they're patients. So you are in the service and support business. I will add, though, that the CIO or whoever the title is that leads the IT department, their role is changing away from being technologists, and their role is becoming more business centric. So a lot of the times, partnering with your peer to get initiatives moving forwards is one of those functions, right? So you are absolutely an influencer because most people don't know what technologically is possible or not is possible or isn't possible. So you become that partner. Yes, 100% agree with my colleague that you need to be a co-sponsor of initiatives versus the person who's leading the charge. But at the same time, you're the one who has to explain the implications of doing something. Because a CFO will always say, turn it off because it'll save money, right? Because
Yeah.
why wouldn't they? Their entire bonus is built on that, right? Whereas you have to be very careful about all the rules and regulations that you have to comply with, especially if you have security in your team. And, this is where roles like the CMIO can be very helpful in this governance committee because they straddle that clinical practice, but also many of them report into IT as well. So they can see both sides of that fence and can be instrumental in that. It's all a negotiation, right? So part of this is negotiating and influencing, and then executing is when the technology team has to turn the actual things off. So I think you have to find that balance. But I think health systems that think that they can use IT to overgovern something or be the art of no will not gain popularity with clinical teams. You very much have to figure out how to help those teams. And that's why even turning an application off has to come with a sense of compassion that sometimes technology teams don't show.
Yeah, it's a good point, and I don't know. I guess I like analogies, and the images pop into my head when we talk about these dynamics. And I'm thinking, and I also want, in that line, I want to talk a little bit about um, the idea of having a good intake review process. And I understand that saying no can sometimes result in shadow IT, but that can't be a paradigm we just say, well, we have to say yes to everything because otherwise they're going to do it anyway, right? So we can't have that. We know shadow IT's reality. We have to stop that as much as possible. I know it's not possible in a lot of cases. People talk about it positively in terms of using it as an indicator of what your customers want. So if you see shadow IT, it's an indication they need something you weren't giving them.
Exactly.
So we've got that, but we do have to have, I mean, ideally in a perfect world, we've got a really good understanding it's really hard to get rid of things, right? We know that. It's hard to get rid of things. Let's tighten things up on the front end and make sure only stuff coming in now is truly vetted. We truly need it because we know how hard it is to take things away. I think, again, the analogy I think of is with children. Be tough up front and say no versus having to say yes and then change your mind. Try that with a kid. Give it back, which is essentially what shutting off an application that someone's happily using is. You have it, you can have it, go ahead and use it, learn it, make it part of your workflow, and now give it back, so to speak.
Yeah.
Um,
And I
so
agree. I
go ahead,
agree with
please.
that. I agree with that. But here's the challenge. So you can have a child and you can tell a child no. But if you try to tell a child no with no explanation as to the why, it never succeeds. And then you have to walk back your decision making process. What I'm advocating for is you can say no, but you have to give the criteria as to how you got there in the first place. Not because you're the CIO and you just don't want to do it, or your team doesn't want to do the work, because everybody tells you they're overwhelmed in healthcare. I mean, if you think the US healthcare system is overwhelmed, go and visit the NHS.
Wow.
Yet their productivity is much higher than any US organization. Their patient outcomes are much higher. Their cost per patient is much lower. So how are they managing to do it and we can't do it because we're always overworked? What I'm saying is whenever you're saying no, using a governance structure, the stakeholder that gets the no usually takes it personally. So what you need to do, and that's usually the job of the person leading, like a CIO type, is sit down with them and explain to the reasons as to why it wasn't a priority, why there wasn't any funding. Maybe they're missing a business case. Maybe they're missing five things before it can be approved, and then offer to help them get there. Because most clinicians that I've ever bumped into will tell me that I didn't know I had to do that, or I didn't know this was the process, or I don't know how to do that. I mean, the
Mhm.
number of people that tell me they don't know how to build a business case and get it to approval, well, of course they don't, because their job is to take care of patients, not to build business cases. That's the team's job. That's the finance team's job. So I think you can still get to the no, but the no with knowledge is much better than the yes because we were afraid and we said yes and then did a really bad job. That's what I think people aren't focusing in on.
Otter, your thoughts?
I agree with that, and I because I think just a straight no is never gonna, without any type of explanation, is again the worst thing you can do is have to walk back that no. Then why even bother having a governance process at all? But I think taking a step back, it's understanding what is the ask. What are you trying to accomplish? So by bringing in this software, you want this vendor, etc. This application. What is the outcome you're trying to achieve? Because that I think is most important in an intake process is trying to achieve or understand what exactly the outcome that you want. We have a litany of applications in our portfolio. I know maybe there's an application that already can deliver it. Maybe we just need to update it. Maybe you're not even aware of it. To the point that was made earlier about folks don't understand or all the time about all the capabilities that currently exist in the tools that we have. So let's have those conversations first before we start entertaining or discussing another application, and then to sit down there and say, okay, well, if we do want to have that application, is it for this really niche area, or is it for, in Providence's case, is this something that is scalable across our entire organization, not necessarily for this one market, this one clinic, this one hospital, et cetera? And so I think really it goes back to trying to understand the what versus trying to talk about that individual application or vendor.
All right, very good. We have some audience questions I'm going to read out and we can address. First, our friend Bill Spooner. Isn't the argument of considering the cost of people sitting through meetings actually rationalizing why not to rationalize the portfolio, given that those meeting costs are soft costs in that they don't go away if you don't have the meeting? That's a lot there. Dr. Chaudry?
Yeah, so sometimes it's what I'm proposing is educational, right?
Mhm.
Because we don't, yes, the costs were there, but they were probably going to be doing something more productive than sitting in a committee meeting, which would have a better impact on the health system. But when you are building a program, which is an application rationalization type program, you still need to do the show back, right? You still have to show that, it costs us $1 million worth of labor costs to get to saving 200K in actual licensing fees. But then there is still a return on investment because without having that application for 5 years, you would potentially get some of that back. So yeah, there's a lot of soft costs. It's no different than writing a business case. You buy a new EMR and it's pretty much 90% soft benefits. Even though people will say you'll get your money back in a year, I'm sure Anthony's talked to enough people to know that they spend 100 million, 200 million on EMR, never get their money back, even though the business case they said they were going to get their money back. But I think it's always good to ask the question. I always ask the question when I'm sitting in a meeting and I look around the room and I say, wow, this 1 hour meeting's probably going to cost us 20 grand, right? And what really irritates me at the end of that is no decision was being made because we tabled it for the next meeting, which could be another 20,000. And for some people, it frustrates them. So when you protect clinical time and you put clinicians in a room to try and make a decision and then no decision is made, then they don't really want to come back for the next meeting because they still have to do their day job. And it's the same for technologists, right? You, as a senior person in a health system running a technology stack, I'm sure you have other things to do than to spend 4 hours a day in meetings where they keep tabling the decision
Right.
for the next meeting. I mean, for me, that's super frustrating, but
Oh,
maybe for
oh,
others, that's a great day in the life off. I don't know, right? But that's where you'll see a difference in having worked in different health systems. That's why you'll see a difference in a US health system and a UK health system. In a UK health system, because they're already broke and they're already 105% of capacity, they honestly need to make the decision in that committee meeting. They don't want to table it for 4 more meetings because that means their hospital is still broke and they're still over capacity. So the decision making process speed is very, very different. And here, many health systems are still at decent margin. So there isn't a lot of focus on, and you can say you are cash rich one day and then 6 months later you're not. That's how this health system is ping ponging. It will be interesting to see from January what happens when the big bill hits and health systems wake up and smell the coffee that they weren't sitting on a bucket load of money anymore.
mhm.
So I think have all the governance you want, include all the people you want, you will get goodwill. But if you keep deferring a decision, that will generate that soft cost over and over and over again.
All right, very good. Otter, I'm going to have you react to a comment from our friend David Muntz. We have some legends here on the line today. It probably would make sense to let requesters know why you said yes. Would be a chance to get agreement on what expectations you have and what kind of outcomes and uses you anticipate. This is a really interesting issue we didn't talk about much this idea of reviewing an application that had been requested and approved at some point to see value derived from it. And this always makes me wonder about who paid for it. Because sometimes, and you guys tell me, sometimes I don't know if this comes out of IT's budget, in which if it's requested by a department and paid for by IT, IT might really want to know if there's value coming out of that. or if it's coming out of the departmental budget, that department leader may want to know if there's value. So what are your thoughts on that comment and this idea of, sort of irrespective of looking at a large batch of applications and saying we're going to need to figure out what we're using and retire some of these if possible, that sort of new process of as we start approving things, that which is approved needs a regular formal process for review at some point to see if the ROI promised
Yeah.
has been achieved.
No, that's a fantastic, because I think, really fantastic comment is that yes, this was approved again for all the reasons that we've mentioned, we've talked about. But are we circling back, and this is where it becomes a program, not a one-time deal. So it's sitting down there and looking back, saying, okay, well, something was approved 2 years ago, 3 years ago. Is it still deriving the value that we thought it would, or we anticipated it would? The ROI that it's coming out of, are there workarounds? So everything we just talked about, I mean, it needs to be a cyclical effect. It can't just be, well, done, checkbox, move on. Let's look at the next application, but have folks understand why the decision was made, what made it get to yes, because I think that's very, very helpful, and folks that may come with a new business case, so they understand a lot of the reasoning that went into to making that a yes or getting to yes. But then it's also circling back. Something that's offering value today may not offer value tomorrow. And that, I mean, I know we brought up the dreaded word already once, but AI, I think that's a big case today. I think that's going to move very, very quickly. Is that something that is offering value from AI today may not be the same value you're going to see in a year or two. And I think it's important to circle back on those things and ensure that, that again, you have a program for doing some of those things. So it's a really great comment.
Dr. Chaudry, a little bit on that, and any more you can give me in terms of helping me understand how different things get paid for, different scenarios, and how that might affect who cares about making sure value's been achieved.
Well, I think traditionally the healthcare costs for IT in a health system is paid by the health system, right? The clinicians generate the revenue to actually pay for the technology. IT is a big L in a P&L business. There's very few health teams out there that actually have side businesses where they're generating enough revenue to cover their costs. It's very much clinical margin that generates that payment. And I think that's not always well appreciated, because anytime you ask for more money or cost to support more systems, then clinicians have to do more cases, more surgeries to pay for that. So I think there has to be recognition of that. But when you're building out new solutions, or people are bringing new solutions they want to the table, clinically speaking, sometimes it's a partnership. Sometimes if you're building a technology that can benefit the org but also benefit IT, then maybe there should be a sharing of those costs. And sometimes it's the department, the clinical division, or some other support service that wants a solution. And then that would require a full business case and a full costing out of not only the software, because I think buying software or buying new solutions is quite easy. Sustaining them is really, really hard. And nobody ever puts the additional labor cost into running and supporting and feeding and clothing those solutions. So best examples are new builds. When people build new towers in their health system, for some miraculous reason, it never comes with any money for support services. But then you turn the building on, and all of a sudden you realize you need 3 people to run around the building to support that, but it was value engineered out. So I think it's very much, the funding is still a central part of money. I know people get into meetings and say, I don't have the budget, but the budget comes from the health system. And so if the margins go up, there may be more money to use. And if the margins go down, everybody has to contribute to that savings model.
All right, very good. We're just about out of time. Let's go with the final thought from each of you. Adar, let's start with you. I'll frame it up this way. Give your best advice to an IT leader in a health system who wants to tackle this. Says, our application numbers are out of control. I'm not comfortable from a cyber point of view. I'm sure some of these are not being used. I'm sure there's point solutions that aren't being used. I know there's sprawl here. I want to tighten it up. And maybe they just are unsure of how best to start. What's your best piece of advice?
My advice would be simple. It'd be don't judge the technology by how exciting it was when you bought it. Judge it by the value that it's delivering today. Organizations that will succeed over the next decade won't necessarily have the most applications. They'll have the most disciplined approach to managing those applications. Innovation requires courage to adopt new technology. Stewardship requires the courage to retire that technology that no longer serves the mission. So the future belongs to the organizations that honestly can do both.
Well said. Well said, Dr. Chaudry.
I would say my final thought is anybody who wants to embark on this journey coming from with a technology hat must do the investigation, must do the partnership, must do the collaboration, must do the communication, and most importantly, 20% of any IT job is sales. So you have to sell people on the dream. If you want somebody to stop using an application, you have to give them the reasons why. You have to give them the alternatives of what they could use. And then you have to actually show them and sell them on that before they're going to agree to turn off their, favorite little toy.
All right, that's perfect. That's about all we had time for today. Regarding continuing education, you can use the link I sent out in the chat box to download a certificate of attendance for your Chime credits or whatever. There are also links to other health system CIO resources. I want to thank our panelists. This has been great for spending their valuable time with us today, and I want to thank you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you.